It is officially 9 o'clock. So, hey, welcome to Euronurse. We meet every Saturday, even when I'm on the road at 9 a.m. Central Time. I got to change that Central Daylight Time because we're going off of daylight time sometime soon. But welcome, everybody. Glad to see a lot of you showing up. It's been great. I'm broadcasting live from the Hyatt Regency in New Orleans. And it's been great. A lot of people coming up that said, hey, I've been watching the show. A lot of people saying, I'm going to watch the show. So it's been a real blast. But we're going to have our same format. We're going to take general questions. So if you have a question, go ahead and hit the Q&A button. Bear with me. Some of this is, I'm working off of an iPad and trying to see all the screens is a little tough. But Lori's going to be reading the Q&A, so she'll take a look at that. But anyway, ask your questions if you have anything to ask. General questions for the first half. Second half, we're going to devote to a specific subject, which is what it's like to attend a SUNA meeting. So if you've been to one before, you kind of have an idea, but if you haven't, I've done a bunch of footage here to show you what I really think is the most fun. And I'm going to be showing that during the second half, and then take any questions that you might have about what's going on, what we're doing here in the conference. And if you're, well, I guess I can't say if you're viewing from YouTube because nobody can view from YouTube today, but I will be posting it up on YouTube later. And I'm going to offer John the ability to become a panelist if you'd like. I just saw he came on because I can use all the help I can get, especially with this restricted screen. But anyway, so let's get rolling here. I'm going to start with, bear with me. I did have a question come in over the week from last week's talk, so I'd like to cover that. So Marty Pickard from Winter Haven, Florida sent this. He asked, if men are able to experience morning erections, is that considered a significant factor in the evaluation? And I'll be glad to chime in to start with. My answer to that would be yes, I think that's significant. Now, if we go by the NIH definition that I gave earlier at the last talk last week, so you have to be able to obtain an erection that's strong enough for sexual performance. So you have to be able to have intercourse with it. So a morning erection may or may not be qualified. So if you get an erection in the morning, but it's one of these things that, when they kind of push down on it, it buckles, that's not going to be sufficient to have intercourse. So they still are having erectile dysfunction. And I would certainly want to know that. Now, another thing that I was thinking about when I got this question, and let's see what the panelists, maybe their thoughts are, but if you're getting a good morning erection, then I would be highly suspicious this could be performance anxiety. So I think that may be a clue. So really good question. And thanks, I think it was Marty. Yeah, Marty, thanks for sending that in. But I don't know, Lori, do you have any thoughts on that?
Yeah, I totally agree with you. I mean, when we get these 20s and 30-year-old men that come in with erectile dysfunction, of course, we do the full workup to make sure there's no underlying cause. But in most cases, it is an anxiety issue.
Yeah, definitely. And John, do you have any thoughts? I see your.
No, actually, the fact that the patient is able to obtain a morning erection indicates that this is more likely a psychogenic versus organic. And like you said, Vic, the patient not only do you need to achieve that erection has to be functional. Meaning you have to be able to maintain the erection to complete the act of intromission, or else it's by definition an erectile dysfunction.
Yeah, good point. That's one of the things that I always looked at in the past, where people would say, well, what test should we do? And I'm like, really, if you can give a history and we can pretty much determine what's going on based on that, and the tests are not going to change the treatment options. So I'm not really, thinking that there's, much use to it. And as I mentioned before, we used to do the old nocturnal erections, and you'd break a band on this thing, or we used to use stamps because they were cheaper. Now I think it's probably more expensive with a stamp, but it just doesn't give you any information, because if you can't use the erection, it doesn't matter if you can get one in the morning and it doesn't go in. So, and psychogenic problems, it's still erectile dysfunction. Feel free, anybody, to add in any questions. Otherwise, I will tell you that we're basing most of this on my experience today or this week at New Orleans. Luckily, New Orleans was spared the hurricane for those of you, and that question came from Marty in Florida. So, I mean, I hope everything went well. He actually, Winter Haven is pretty close to where my son lives in Florida. And I talked to him and he said that a lot of rain, but they didn't have much, it was windy, but nothing that was damaging to their property. So they were happy about that. He said just a lot of rain.
Yeah.
So my heart goes out to those people in Florida. That was a tough storm from watching some of that footage. But here in New Orleans, it's been high in the 70s, 80s every day, sunny, been absolutely beautiful. Been doing a little touristy stuff around the city. We went to the World War II Museum. If you've never been to it, it's absolutely amazing. I think it was Tom Hanks who built that or supported it but it just, I always thought I knew a lot about World War II. It's amazing that when you learn the real history behind it and how close we came to not winning that war. It's a little scary. So it's a nice trip. And the conference hall is the Hyatt Regency. It's absolutely beautiful the way it's laid out. And I'll be showing some footage for you guys that are at home that aren't seeing it live to show you what it looks like. But it's a great experience. I would like to talk a little bit about EuroNurse since we're still waiting for any questions to come in. Thanks for all the support I've had from you guys, all you attendees. It's been great. And let me tell you, people in SUNA know about EuroNurse. Everywhere I go, people have stopped me and said, hey, I'm watching the show. Or if they haven't watched it yet, they're saying, I heard about it. It's a resounding, hey, this is a great idea. Couldn't do it without my fellow panelists. Laura, you've been with us from the start. So, but just to let you know that we're on their radar. They know that we're doing, some interesting things. One of the quotes that I heard somebody say, SUNA National, one of the people from the Genetti group said, wow, this Chicago Metro is really exploding. I go, what do you mean? He goes, well, you got a conference every week. I go, oh yeah, because they see the Euro Connect and that's through SUNA. So that's the way we're reaching out. So tell your friend.
Every time we have this, there's something that I bring back to my office, which is great. Like, I think I know it all and I don't. So, yeah.
Do we have any questions out there from the attendees? We're glad to listen. If you want to just give a shout out on something, that's quite fine too. See a lot of names that are familiar. I did mention that I can't remember her name, but somebody from Oregon actually stopped me and told me how much she liked the show. And I think she was going to tune in today. She was saying, yeah, I'll see you on Saturday. Maybe she'll see me Saturday when I talk. Today, I am giving a talk on technology and urology, how we utilize it and how you can make your work more efficient with some of our current tricks. And I'll share some of those, of course, with this group.
Oh, Melanie. Her name is Melanie from Oregon. Welcome, Melanie.
Melanie, there we go. Great. Welcome. So sorry about the short memory, but it was a pleasure to meet people that are viewers. So I think Lori's going to become the next rock star, with everybody's going to, she'll be going out in public and they're saying, I know you,
right?
You're a nurse.
I wanted to bring something up that I wanted to bring up to whoever's on. And this was brought up yesterday. What do people do for post-vasectomy semen analysis? When do they do it? How often do they do it? If the lab comes back non-modal, rare, we're just kind of going through this debate right now with all of our providers. So I just wanted to get an opinion of what everybody does.
Well, you don't need to get an opinion from us. You can look directly at the AUA guidelines.
And I did.
Yes.
Yeah.
AUA guidelines. As the number one vasectomist in Arizona, and last year alone, I performed 1,200 vasectomies. And this coming Saturday, I have 22 scheduled Saturday morning.
That's how we are too.
I have a little bit of experience in doing this. Initially, initially I saw the patient twice, and then semen analysis was done also twice. but then I started following the AUA guidelines. Now I obtain semen analysis once, at least 3 months, and 30 ejaculations later. Once that semen analysis demonstrated no sperm, then the patient is considered sterile with a failure rate of less than 0.05%.
So is it 30 ejaculations or 3 months? So
No,
if they do
and so I tell the
the end,
patients this:
okay.
the longer you wait before you obtain that semen analysis, the greater the chances of that one sample will show no sperm. If the man waited 6 months, the chances of having that one sample showing no sperm is much higher than 3 months. That's been my experience.
Okay, that's great.
I'm sorry, I'm confused. So that's with no ejaculation, 6 months later, should show no sperm. You're not going to see dead sperm.
I tell the patients the longer you wait before you have your semen analysis, the greater the chances of that one sample will show no sperm. He would also engage in protected sexual intercourse until that one sample, or until a sample demonstrates no sperm.
Okay.
So my question too is also, if you get that semen analysis that comes back, I know that the AUA guidelines, I believe, said that non-modal sperm, rare, is considered a negative. Is that correct?
First of all, I would never, and I counsel this to my staff, we never tell the patients whether their semen analysis is negative or positive. I know of a case where the urologist was sued above the limitations of his coverage limitations of his medical malpractice insurance because of a wrongful birth secondary to the MA giving the patient or the wife that, oh, your semen analysis was positive. Well, positive to the patient may mean, great, no sperm. We can engage in unprotected
Oh
sex.
boy, yeah.
So we always tell the patients, you have no sperm in your sample, or you have sperm in your sample, and you are not yet sterile, or you are sterile, and you, or whether or not you can or cannot get someone pregnant. We try to dumb it down so that there's no misunderstanding or miscommunication. And the AUA guideline is fewer than 100,000 non-modal sperm. So not often anymore, but in the past, I have received semen analysis samples demonstrating 1,000 or 5,000 non-modal sperm. And this is not the post-vasectomy semen analysis. These are the semen analyses that you perform for infertility, meaning these are fresh samples. And when they showed 1,000 or 5,000 or 10,000 non-modal sperm, I tell my staff will inform the patient that the AUA guideline states that this is considered sterile because they're dead sperm.
Yeah.
They're most likely just lingering.
So what do you do for the people that come back positive though? What's your recommendation on what they're supposed to do next?
Showing modal sperm?
Modal, or I mean, even if it's greater than, you said 100,000?
Then I tell the patient that you are not considered sterile. Continue to use pregnancy precautions, and then get retested.
Do they get retested right away? Month, 2 months after 15 ejaculations?
A
Okay.
month or 2 months
Yeah.
later, yeah.
Okay.
And you also asked, go ahead.
Have you had to reoperate on anyone?
It's extremely rare. Most of the failures in my hands occur early on. And so at 3 months, if they're showing modal sperm, and after, so typically they'll undergo 2 post-vasectomy semen analyses. And if both show sperm present, then they will undergo a complete semen analysis. And if that shows a lot of modal sperm, I consider that a failure. Most of the failures occur early on.
Yeah.
And thankfully, it's extremely rare.
Yeah.
Good. That's good discussion.
And you also asked how the semen analysis is done. It's a pain in the butt. It's a pain in the butt to have to go to a lab or collect a sample at home and then take it to the lab. Now there are mail-in semen analysis that you can perform at home, and then you mail it in. You get the results back in a couple of days.
So what are the recommendations as far as once a patient submits a sample? We have this ongoing with our lab that they're saying it's okay up to 24 hours after, but you can't determine modal versus non-modal after 24 hours, correct?
Well, that's why the post-vasectomy semen analysis, I just want to know whether or not there is sperm present. And you are correct. You can't tell if they wait a long time. So the sample that you provide for that post-vasectomy semen analysis is different. The way that it's gathered is different than for infertility. Infertility, you need a fresh sample. Post-vasectomy semen analysis, I just want to show goose eggs, 0 sperm.
Gotcha.
So the threshold is set really, really high. The bar is set really high. I tell the patients, I'm taking 20 to 250 million sperm per cc, and every time a man ejaculates, it's about 3 to 5 cc's that comes out. Yes, despite popular belief, only about a teaspoon or a tablespoon. That is what is normal, despite popular belief. And I'm taking that. Yeah, go ahead.
So what if you get a sample? Like we get a lot of samples that that are below the normal milliliters. Do you still accept those?
Yes.
Like they have, you do. Okay.
Yeah.
Because sometimes our docs will be like, oh, it's too, small of a sample. We need to get another one. And I was just curious about that.
Yeah. Ideally, you want to get a normal volume, but the WHO definition of what is normal has a range. That's why 20 to 250 million sperm per cc. That range is the norm, if you will.
Okay.
So I'm bringing that number 20 to 250 million down to 0. So I set the bar is set really high.
Right.
And just you don't want a failure. The patient certainly doesn't want a failure to, as you said in that example where he found out they were pregnant. And I wonder about it's a good practice in your particular institution to make sure that they're not saying positive, negative. But I wonder how many other practices are adhering to that. I think that's so important that you make sure that how you explain to patients what their results are, that they're understanding it.
Yes.
Yeah, we're actually in our practice, we do one semen analysis 4 months after.
That's great.
And that's it.
Yes.
They don't have to repeat unless it's positive.
That's great.
And then after a year, if it's positive, then they'll go for a full semen analysis.
Yeah.
Yeah.
That's reasonable too.
Yeah.
I think our office, I don't know if it's changed recently, but it was 3 samples they wanted to see before.
Wow.
And every time we gave the results, it was there was no sperm seen. You still need to continue to use birth control until we see 2 more samples. And then it would be, there's no sperm seen.
Wow.
Still use birth control until we see 1 more sample. And then it was, the party balloons and hey, everything looks fine.
Which begs the question, your compliance rate.
Yeah.
Yeah. I think the first 2 were high, but actually I was surprised. Most of them I would get the 3rd because a lot of times I'm the guy who got to give that good news.
So some of our doctors will actually require the patient to follow up in 4 months after a vasectomy. And if they ensured that they did their semen analysis, they can cancel that appointment. But if they're on that schedule for 4 months and they didn't do it, that's how we kind of track our patients.
That's a good idea.
Okay. That begs the question, what is the medical necessity of having that patient come back at 4 months if all you wanted is a semen analysis?
There is none.
Except
to ensure that they have that semen analysis.
Even though it is outside of the 90-day global period of a vasectomy, we're talking coding and billing now.
True.
Even though it is outside of the 90-day global, you have no medical reason to bill for that visit. So you're doing that visit for free, right?
True, although we would catch it because we, of course, check our charts the day before and so we'd catch that and then just make sure we call the patient and just remind them. After that, we don't track it anymore.
Yeah, so you want to make it as easy as possible for the patient to obtain that semen analysis. And we have found some of these mail order companies is the easiest. Either you can have the company send the kit to the patient, or your practice can buy the kits and then you can sell the kits to the patients. He will take it home after his vasectomy, perform the semen analysis at 3 months or 4 months, and then mail it in. And in 2 days, he'll get the results.
Yeah, I think that makes a lot of sense. Plus, you've got a record to.
Yeah.
All right. I don't see any other questions coming in, so I'm going to move along with the next part of the program. If you have a question that you come up with while you're watching, I'm going to show you what I've been doing for the last couple of days here in New Orleans. For those that have never gone to a SUNA meeting, hopefully this will inspire you to want to go to one. Bear with me because I have to figure out how to share this.
I'm actually looking forward to hearing some of your technology and urology talk. I'm a techno geek.
That's going to come up later. That was a tease for that one. All right, let's see. Here we go.
And I'm not, so I should be there.
All right, let's say hello real quick while Vic is teeing up. April, Charlene, Diane, Lisa, Melanie. I love the way your name is spelled, Melanie. Neil, Rachel, Rochelle, Rebecca, Robert, Susie, and Teresa. Thanks for joining us.
All right, I'm going to go live. Hopefully my screen should be the full view. And here we go.
Hey, here we are at the registration desk. I'm just getting all my registration stuff. Here to pick up my badge and stuff. There it is, all ready to go. Wow. Thank you very much.
All the sessions will take place in this hallway here for you.
Okay.
Exhibit halls, great cafeteria, storage rooms, and then at 6 o'clock.
6 o'clock tonight. All right. Are you eating food there?
Yes. Some refreshments and some snacks.
Sounds good.
Yep.
See you then.
See you
Really
then.
shouldn't be in here, but I just wanted to, I'm dying to give you guys at least a early look at what goes into all of this setup here. So there's going to be stands everywhere. We'll hopefully have some reps that'll be willing to talk to us on camera, and I'll bring that film to you later. I just got here, just registered, and we're going to see what happens. So it's nice that all the meetings are held in the same area. So this area will be all the different meeting areas. We got refreshments, got to have those. So it's empty right now because we're here before the conference gets going, but this is exactly where it's all going to take place. This will be the first place I'll be at tonight. Right here, the business meeting and awards. Hopefully our chapter will win an award tonight. We'll find out at the business meeting. It's going to be starting pretty soon, but I thought I'd give you a quick look ahead of time and see what it looks like at a business meeting. People are starting to pile in, and we're going to have some really good action going on, so stay tuned.
Presidency started off kind of with a bang, being virtual during the pandemic. My first year, virtually everything was virtual. And so we really had to learn how to do things differently. I was really blessed to have the annual conference in my hometown, first one back in person after the pandemic. And it was so much fun being in my hometown with a lot of my local friends, reps, everyone around. But now, as I'm going to be passing the gavel to Glenn, unfortunately, this presidency is kind of ending also with a bang, with Hurricane Ian, whoever, one of those hurricanes, kind of screwing up things with hitting Florida and causing some of our members, planning committee chair,
So this is a new product that I just happened to come across for incontinence.
The quick
Have
change
you
wrap.
check it out. Yeah,
Go to quickchange.com.
there we go.
And just so that you know, the quick change wrap has been on the market for 5 years now. It's in some of the most respected systems, hospital systems in the United States. Baylor Scott and White, the Mayo Clinic, Cleveland Clinic, UCI Medical Center, Keck USC. It's also been approved 100% by the federal government through the Veterans Administration. So it is on the federal supply schedule for the veterans, as well as their outpatient. And the real wonderful thing about the Quick Change Wrap is we were just picked up by Walmart. You can get the Quick Change Wrap on Walmart.com, Amazon.com, and our website. And Medicaid is covering the Quick Change in almost all 50 states.
So this will hold 500 cc's.
Guaranteed.
Do you have any idea what they cost?
Approximately $1 a unit.
And you did say they're available on Amazon too.
Absolutely. Penis goes up.
Hey, how you doing, Lisa?
Hi, Vic. I'm good. How are you?
I just came to the WellSpec booth to talk with Lisa a little bit about what's new, what products are out here.
So we have Lofric L here. Lofric L is our newest female length catheter. I'll show you how it works. So you pop the top first, and then you twist here to release the integrity seal. And then this container is recyclable. So this has some wetting solution in it. You'll want to discard that. And then there's an optional handle. So the handle, which is the container of the catheter, it attaches to the side. So there is a little circle over here, and there's 2 buttons at the end of the container. Twist in, and then you can hold it like this. Completely optional, but the Lofric L allows more women to be able to catheterize independently. So we also have this mirror here, and I just want to demonstrate how using the handle will help relieve any obstruction that you may have from your hand. So when you're not using the handle, you can see, placing your hand in front of your hand's in the way. So by adding the handle to the catheter, you really, you have a better view.
Mind if I
Sure.
take it for a drive? Oh, it really stays in there. Oh, that's new. That's unique.
Yes, it is. It's one of a kind. It's the first intermittent catheter with a handle.
The nice thing about coming to these meetings is you find new products that you may not see all the time in your office. You're busy all the time, so this is a great opportunity to learn about the latest and greatest. I really appreciate it, Lisa.
You're welcome.
right,
Good to see you, Vic.
One thing interesting is to see all the different poster presentations. What we mentioned in our last meeting, talking about another subject that would be good to talk about, female sexual dysfunction. There's a screening tool about what this is and what it means.
Sure. So essentially what we assessed was the use of mechanotherapy in women with stress urinary incontinence, and are those results sustainable over time? So what mechanotherapy is essentially adding load to the pelvic floor. So it's looking at it with the use of this product 2 different ways: by stretching the tissue to prepare it for movement, and then by adding a little oscillation. So what that's doing is creating cellular change in the tissue and naturally helping to recruit more muscle fibers. So that combination of mechanotherapy is paired with an active Kegel contraction. And so what we found with the use of that is we assessed pad weight in the initial part of the study. We looked at the ICIQ and the iQual. And as a full cohort, we found that pad weight continues to improve over time. And by the end of 12 weeks, as a full cohort, their pad weight was down to just about over 6 grams, and we classified continence as to less than 10 grams. With the ICIQ, continue to improve over time as well. And even when we break it out into severity of symptoms, them as a whole cohort continue to improve even based on severity. When we look at quality of life data is a higher number denotes improvement. And then when we break it down into severity of symptoms, mild, moderate, and severe. So no matter the amount of severity somebody has, they're kind of all the same across the board from baseline to 12 weeks with that significant improvement in trend. And the most interesting aspect that we found is even after 12 weeks, so we followed them for 2 years, So after 12 weeks, the majority of women discontinued use of the product, and those results were sustained and even in some cases improved after 2 years.
Wow.
So what we found as a trend, it's a really effective treatment. It's just 5 minutes a day, at-home treatment for women, and they can improve their stress urinary incontinence. So those muscle changes are happening, improving strength and tone, and gaining the incontinence. And those results are sustained and demonstrate durability over our 2-year follow-up.
That's great. I always find there's a great need for more non-pharmacologic treatments.
Exactly. Like there's other options out there versus just medication and surgery.
And I'm sorry, I didn't catch your name.
My name is Leah Folger.
Oh, very good.
Yeah.
Great.
Okay, I should be back, right? Can you hear me?
Nicely
Great,
done.
Vic.
Nicely done.
Actually, yeah, I really miss the conferences after looking at that. I'm like, oh my gosh, you meet so many people at conferences, no matter whether it's local or national. It's so great to see people.
Yeah, it was fun. It was a little tough to try to, shoot everything on a phone, mix it on an iPad. You don't have all the stuff I'm used to for when I work on video editing, like color correction and noise reduction and all that. But I thought it came out pretty good.
Yeah.
And of course, I give credit to my wife who was holding the camera most of the time.
I saw her walk by and I'm thinking,
Yeah.
So who videotaped that one? I saw her walk by at one of them.
Yeah, I was walking around looking at the posters. The two people one I was interviewing is a physical therapist, and so I told them about Euronurse, and they said they would love to come on our program. So I've got their information, and we're going to schedule something to talk about how physical therapy treats incontinence. So it'd be interesting. That was one
I
of the
think
nice.
it's great that you have that whatever that was called, the pad that held 500 cc's for a male, and
Yes.
I
Quick
think that
change.
was awesome.
Quick change.
Yeah, $1.
Wow.
It's true. I just looked it up. $1 per count
And she
on
was so
Amazon.
that it got on Amazon and Walmart. So I think it's, these are great products, these ultra absorbency things, because, you have skin breakdown to worry about, but cost is a big issue for patients. You put a diaper on somebody, now you've got this big bulky thing that you're wearing that's going to possibly cause chafing and things like that, where it's not stool, it's just something to suck up that urine. And I mean, I don't think it'd work on somebody who's, mobile, but it's an interesting product. I think it's going to be something I would recommend to patients.
Well, and the fact that, most patients don't use them or use, Depends or whatever, because they're too expensive. And so they just wet the bed. They don't do anything about it. And these are great ways for these people to use something that's hopefully less expensive. $30 a month. Hey.
Absolutely. And I think it's
Something-
always a big plus when you can just buy it yourself, go on Amazon and order it.
Right.
Something that is not so inexpensive that works well for females is something called Pure Wick.
The Pure Wick, yeah.
Yeah. So it's great to have that quick change. Mechanotherapy, that's very interesting. And then low fric L. I think that's a great idea. Not everyone has good hand dexterity, and that's one of the biggest concerns for my men and women who have the South Cath, and having that L shape makes it a lot easier for a lot of the ladies, and giving them that independence is really, really important.
Yeah. And I think that not everybody needs that extra handle, but as she was, and I don't know if I caught the angle very well, but she had a mirror there because some females really need to use the mirror to try to aim it. And as she was showing, now you can't see because your hand's in the way. It's blocking the mirror. That L gets you off angle enough so you can see where you're aiming. I mean, I think I always walk around and say, what's new and exciting? And she said, well, I think I've got something for you. And then was willing to record that for us. So that was nice. And that's what you get at the meetings.
And we can chat, Vic, at the after party about how whenever I go to these conferences, how I interview these vendors and the tech that I use.
Yeah.
I'm not aware of anyone who does what I do. Every meeting that I attend, and a lot of attendees don't realize this, these vendors, to have these booths at these meetings, cost them thousands of dollars, plus the actual people who have to be there for multiple
Yes.
days, the travel expense. And so it's very, very expensive to these vendors to help support the meetings. And just the attendee fees is not enough to allow the like SUNA or AUA to put together these meetings. Without industry support, it just doesn't happen. So every chance I get, whenever I can, I will go out and interview some of these vendors, and then you can see it on my YouTube channel, actually, John C. Lin MD. I interview a lot of vendors and try to bring that information to those who can attend. It brings value to the vendors, and they love it, and it encourages them to want to come back and repeatedly sponsor the various meetings. And we can talk about the tech afterwards.
Absolutely. I mean, that's the whole time I'm doing this. I'm thinking, oh my gosh, I should have a handheld mic, something that I can, get better audio. Of course, you leave with what you've got, and you think, okay, I'll see what I can do. And amazingly, I mean, all this thing was edited on iMovie, which is built into the iPad. And I've got the iPad Pro, so it's the highest version. But it's just was amazing at what I could do, because I haven't edited a lot on it. I use Final Cut Pro on a big one. And I know I'm getting geeky here for some of the audience, but it was fun to do. That's all I can tell you. And I agree with John that, being able to share this with the vendors, saying, hey, here's an opportunity if you want to talk about your product. They lit up. It wasn't anybody like, oh, I don't want to be on camera. There was a few attendees that I offered to put on camera, and they were like, I don't like to be on camera. But they're I told them it'll be out on YouTube, so people are gonna see them and learn about products. Especially, I think that one incontinence product was neat, and some really good speakers out there. They hawk this stuff all day long, so they're balanced, or they're well polished at putting on a presentation.
You'll find that pharma will most likely not talk to you, or if they talk to you, they didn't realize they couldn't. They'll hear from corporate after my video goes on YouTube. They'll hear from corporate, and corporate will tell them, hey, would you mind telling Dr. Lin to take down that video, because they need a specific person in their company to speak on medications, right? Whereas supplies and durable medical equipment, they have looser guidelines, so they can talk about their products on camera.
Absolutely.
And it's funny how you see all these reps that come in, and just for example, like we just started doing Xiaflex, and this person comes in to help us with the first Xiaflex, and she's not clinical. So I'm like, I'm asking her questions, she doesn't even know how to answer. Like it's amazing how these people are trying to help you, but they're not clinical at all. So the best information comes from the clinical experience, period.
Well, I think being a rep is not very easy, because you have to balance that clinical knowledge with people skills and knowledge about coding and billing and reimbursement. So I think they have a tough job. And certainly for something like Xiaflex, you definitely need someone who is very clinically oriented and also knows the reimbursement aspect.
Yep, absolutely. And it's kind of nice to be able to reach out and talk to people about their products and see what's being utilized. And I'll always find, it's never been a meeting I've gone to, I haven't found one product that I'm like, didn't know about that. So if you don't go to the meeting, a national meeting, certainly go to your local meetings, because again, at our chapter meeting, which is coming up
November 19th.
November 19th. So for those that are in Chicagoland area, don't miss the Chicago Metro SUNA meeting. It's going to be a great one. Go on to euronurse.com. There's a link right to the Chicago Metro website, because Chicago Metro was the one who generously donated the money to fund for the webinar cost on this. But the upcoming meeting is going to be great. And for those of you that don't live in Chicago, Chicago's a nice place to visit. It's a hub. Southwest flies into Midway. It's real easy to get from Midway over to the hotel that we're hosting it at. So, and they've got great accommodations. And we've got vendors.
Yep.
And
And I've
John-
actually talked to some of those vendors.
Yeah, as John said, you can't put on a meeting without vendor support.
No.
The cost of this stuff is tremendous. Well, it's great. Any questions from the audience? Anything you want to know about the meeting? Do you care whether I enjoyed it or not, or did I learn anything? I'll tell you, so far I've gone to, I went to a really good talk last night on Peyronie's disease, and it was very interesting. Learned a few things different, some of the surgical stuff they're utilizing and the techniques. Also went to a really good one on testosterone replacement therapy. I'm going to try to get that speaker to give us a talk. It was our own Chicago Jeff Albaugh was speaking on it, because I was always under the impression that patients with prostate cancer could never be on testosterone. Well, I shouldn't say never be on testosterone therapy, but it was, as he put it, it's being taught that it's like throwing gas on a fire. And the logic has changed, and the AUA guidelines have changed, and it made a lot of sense, because the big thing he was saying is, think about the patient who has prostate cancer and has a normal testosterone level. We don't suddenly take them down to nadir for treatment. So he said it doesn't make sense that a patient should have to suffer with low testosterone. So we need a speaker. It's not my subject, but that'd be a great one to talk about. And the other thing was the cardiovascular, that pendulum back and forth. Does it, improve cardiovascular? Does it cause cardiovascular disease? So it was a really good meeting to attend, and I'm going to hunt the speaker down for that one.
There certainly
Lynn?
isn't a shortage. Go ahead.
Oh, sorry. I got a message from Melanie. We're not getting many questions, but she did say, Dr. Lynn, it would be great for you to be a speaker at our next SUNA conference. It's taking place the last week of October in 2023 in Phoenix.
And I privately answered her with my direct contact information, email, and my cell phone.
Oh, I see that now.
Thank you.
Yes.
Wow, look at that.
It's awesome.
I agree. And Dr. Lynn is going to do one of our talks. We're getting a date for him to speak on our program here at EuroNurse. But always great contributions every week. It's been a great thing to have this panel together. So.
Just like what you're doing, Vic, you're doing this. I mean, you're semi-retired. You're doing this because you want to pay it forward, and that's why I do this. And also, besides that, I'm still practicing, so I'm learning from both of you. You have more years in urology than I do, even though I'm older than Lori.
Hey, now.
We're all
not by
older,
much, but
Lori's such a youngster. Hey. Enjoy it while you can, Lori.
I know, right?
Yeah. Well, one of the other benefits of attending these meetings is you get to network, and by network, I mean, hey, you're in the next town over, or you connect across the country. And if you want to connect with these vendors, if you have an idea, they may be able to help you bring it to the fore, or you may end up serving on an advisory board of theirs if you have a particular subject matter knowledge regarding their product. So there's so many ways that you can connect with other people, and so many opportunities, if you will, by attending these meetings. That if you ever wondered why pharma and medical device still sells by using people, putting people in front of you, it's because they can close deals much better with in person, and that in-person connection is so important. That's why when I initially see a new patient, I'm going to see that person in real life, and then subsequent follow-up, when appropriate, I can do it with telemedicine.
Exactly.
Yeah, you need that connection is really, really key.
All the technology is a tool. It doesn't replace the one-on-one contact. And again, being in a big meeting like this, it's nice just to kind of reach out and meet people that I know from around the country that I just don't see more often than when we have a big meeting. So it's a great connection time to get back and, hey, how is everything going? And always, as you say, you learn something from somebody. It's not a one time you learn it and you're done. And that's why you folks are out here. I know you got a thirst for knowledge and you want to learn more. And it's great because what you're learning here, you're bringing back to your patients, and they're the ones that are benefiting. And that's the bottom line of why I do it.
Yeah, and the fact that we're taking our time on Saturday mornings from 9 to 10, I know it's hard, but taking our time, we don't get anything out of this other than obviously a lot of more knowledge. We're doing this for ourselves, not for any kind of benefit.
Yeah, that's right.
And not a paid gig.
Nope.
Nope.
But I enjoy it every week. I look forward to it.
But I'll tell you what, some of the things that I don't get paid for are the things I enjoy doing the most. So there's more to life than money.
Yep.
But it helps pay the bills. Well, at this point, there's nobody else with questions. I'm at an active meeting, so I'm going to try to sneak off and get to the next talk, which happens to be medications for erectile dysfunction. Just see what's new, because you got what was old last week. So I may be adding some new updates after I go to this meeting. The after hour is always available. I just may not be there because I'm going to be gone. But if anybody wants to join it afterwards, go ahead and click it. The link opens and it'll shut on its own.
Vic, we have a couple of questions real quick.
Oh, go ahead.
Oh, so Rachel Smith said, would love to hear more about testosterone therapy or replacement therapy. Would be curious to know if anyone uses sub-Q testosterone for patients. And then we also have a question about where's the next SUNA conference going to be, which we have a spring and a fall. So I guess the question is where the spring one
Are they
is?
referring to the big SUNA conference?
That's a good question. So
I'll
that's
answer the
Susie
question.
Swain.
The big SUNA conference is going to be in Phoenix next year.
But isn't there a spring and a fall?
Well, there's a Philadelphia for the advanced, it's called the Urologic Advanced for the advanced.
Yeah.
And that one's going to be in Philadelphia.
So the next Chicago Metro SUNA conference will be on November 19th, and that's at the Hyatt Regency in Lyle, right?
It's in the Sheraton.
Sheraton. Okay,
Sheraton.
sorry. I know
It used to be at the Hyatt. We
forth.
moved to the Sheraton because they've got such great facility. They have a huge exhibit hall, which the exhibitors love. And then the meeting area is atrium seating. So you've got that staggered stage.
Yeah.
Get a great view and great acoustics. So we look
Good.
forward
And
to
as far as the testosterone replacement, we haven't used sub-Q testosterone. I went from a place that I worked for a long time. We gave a lot of testosterone, these testosterone cypionate IM. Where I came to a place where actually our office, unless they do the pumps or the pharmacy ones, the patches, their own injections, we don't give any testosterone in our office because the providers choose not to want to follow that, so they send them to endocrine.
Oh, yeah.
Yeah.
Our favorite has always been the pellets, the implantable testosterone.
They are
pellets.
thinking about actually doing the pellets because we have physician's assistants and they're allowed to do pellets, so they may be managing these people in the near future. But other than that, we don't do testosterone other than pharmacy.
And the subcutaneous is that new one, I think, that came out. Exo, can't remember the name of it. Maybe John can address that one.
Is it a Veed? A Veed? Or maybe not.
I believe Avid's a pellet.
Oh, it is. Okay.
Avid's an injection.
Is an injection? Sorry.
Oh, it is.
That's all right. That one I remember. But there's a new one that just came out, though, and I can't think of the name of it. Newer one. Hey, panel out there. Anybody remember it? See, that's why I'm not speaking on testosterone.
I don't remember.
I heard it last night, but one of the disadvantages why I like this format, 1 hour, is I can remember things for an hour. But the format at the national meeting is you wake up, you start going to meetings. When the sun goes down, that's when you go down. Well, actually, that's when you do some extra meetings. I went to a leadership meeting last night with all the chapter heads to discuss what we're doing differently and how we can help each other. So, well, it's been a great meeting. I appreciate your help, everybody. Again, join the after party.
Zyosted.
Zyosted. Thank you. Thank you.
Never heard of it.
Yeah.
XYOSTED. I interviewed a rep, and that interview is actually on YouTube with 11,000 views.
There you go. So if you want to learn more, you can check the YouTube video out. And again, I'm hunting right now. I've got a couple of people in mind that do testosterone to try to get somebody to speak on that for our group, because I think that's definitely some area we want to. Well, we cover anything. Whatever you guys tell us, we're going to find a speaker. So I've got a good list of people that want to talk, which is a nice start. So we got to keep this going with interesting stuff. All right. Well, I'm going to say goodbye to everyone. I'm going to get off to my next meeting for the rest of the day. It's been great. I'm glad we did this. It's kind of neat to do the remote to see if it can be done. So, John, thanks a lot. Lori, thanks a lot.
Yeah.
And all
Thank you
out
Vic.
there, the ones that are at the meeting, say hi. And the ones that are not, we'll see you next week. Next week,
Vic,
remember,
thanks.
Complicated Catheter Problem by Todd Thompson.
Vic,
All right,
thanks
go
for doing this.
Yeah.
you're
Thanks, Vic.
All right. See
Thanks
y'all.
everyone for joining.
See you at the after party.